on this computer. Hey guys, welcome to the 1st of spring, 1st of September for us in Australia, which means it's actually the first of fall in a handful of hours for everybody in the Northern Hemisphere. The light here is appalling. I do apologise, but our morning sun is not conducive for good light source. And I'm just throwing things around my room right now, trying to make things better. But I do have Bruce here, who is going to give us a hand today with looking at some options for the neck and first rib, which is what Anna actually asked about in our chat group. So I'm just going to go through a tiny bit of anatomy first. We have to look sideways because he's up too large to stand up and I was too lazy to put the screen up higher. But when you look at the anatomic positions of the spine, you've got the head at the top that rotates on our atlas and axis. And then you can see there our, I'm going to see if I can just get my background into a virtual background. Is that any easier or not? Yeah, if I lean forward. Okay, so you can see that as C2, his better or worse, no. C2, which is our main palpable joint that we can actually normally feel, that we can, if I get my blue behind it, there we go. That C2 is our main palpable spinous process that we can feel when we're treating. We can't feel anything above, it's impossible. The soft tissue of the suboccipital muscles is just too thick to be able to feel anything. You can feel the bony innominate space of the spinous of the actual skull, and then we come down and we palpate through to we come down and we can palpate the lateral borders, which is probably what we're going to be more focused on as therapists. We're going to come into the lateral sides versus the spinous processes. We palpate down the spinous processes for general information on restriction and stiffness, but we come to the laterals in our facet joints to actually see what kind of mobility is going on through there. And when I'm palpating for lateral facet joint stiffness or overall neck stiffness, if you can see here, we've got the mastoid process just here, and to palpate, we have to come forward of that. So a lot of people are coming way back in the head to try to palpate the facet joints of the cervical spine. But in actual fact, you have to come forward of our mastoid process, and then you'll palpate. And you can just generally spring. Now you can do it two ways. You can have them lying prone, which means that their head is cradled and their neck is going to be into further extension. So you'll have a greater lordonic curve. And you can be compressing down on each joint, like so posterior to lateral or posterior to medial or anterior to medial. So anterior, you're standing lateral to them and you're pressing down towards the hyoid space. Or you can have them lying supine, and that way you're cradling their head in your hands, and you're just using your fingers. I normally use my middle finger because it's the longest one, and I push one side and then I push the other, and I just feel what kind of lateral translation they actually have. And that's a really nice way to get a global and overall assessment through there. And then we come down to our first rib, and underlying that is our second ribs. Now, we can't actually palpate the first rib really effectively at all. It's such a hard rib to find. The only way to do it is to actually find your trapezius muscle, come anteriorly to the trapezius muscle, and then sink down into the tissue, go posterior and down. And really, you'll only feel it if it's elevated. So if the first rib is elevated, it will actually also pull the second rib up a little bit with it if the scalene muscles are involved. So when you think about our scalenes, they're going to be coming down the lateral side of the neck, and the anterior and medial will attach on the first rib, and the posterior attaches on the second rib. So when we've got any neck pathology that's involving restriction in our lateral flexion, which happens, we have more restrictions in lateral flexion than we do in rotation and flexion extension. I think it's probably because the movement is actually less. Most of our movement is the upper cervical. Very small amount of movement is our lower cervical. It's not like a lovely glidey curve. We don't expect that because the joints are such close space. We're really more used for rotation, and that's come right back to our primordial days where we're looking at, that's our fear related. We have to learn to be able to see around in those spaces, and those spaces, not so much lateral. Scalenes can get tight, especially if people are have a lot of respiratory dysfunction. So respiratory dysfunction can happen in a couple of ways. We can have respiratory pathology, so COAD, so chronic obstructive airways disease. You can have asthma. You can have other kind of respiratory function issues. COVID is a biggie right now. Secondarily, you can also have restrictions because we're under stress. Now, stress will change our breathing patterns. So we're actually not going to be breathing as effectively diaphragmatically. So we're going to be using more our scalenes and our accessory muscles, pec minor, intercostals, serratus to assist us in that kind of apical breathing. And that will always load up our scalenes. So I'm going to show you a couple of videos that I've got embedded that will assist you in trying to see how we can mobilize the first rib. We're also going to do I've got a little video that's going to mobilize the AC and SC joints. Now, when we can move the AC and SC, you can see here, because the AC joint attaches to the manubrium and weaves around to catch up to the scapula, if there's a restriction in the first and second ribs, and the second rib is elevated, it's actually going to change the biomechanical play of that whole area. So don't be surprised if we can't access the second rib and first rib effectively, but we can do some work on the shoulder and it will give subsequent changes to the neck. I've always said, don't stick in one area of dysfunction to expect that you're going to change the dysfunction. We can change it by looking at multiple areas. And we all know that the lumbar vertebra and the cervical vertebra are mapped up as well. So those are always going to be something to consider. I'm just going to put Bruce away so I can screen share. Wait a second, Bruce has actually vanished with that screen. There we go, Bruce. Good old Bruce. And we're going to come back here and do a different screen share. Come down to, sorry, just going to move this bad boy around so I can come into, wow. So you should be able to see this screen. I'm just going to start it. Hans, can you, or Hayley, can you see the screen with first rib function on it?
Yep, we have the video up.
Yes.
Right. Yep. Okay, great. All right, I'm just going to hit the play.
Okay, you're not sharing the sound yet.
Okay, hey. I suddenly realized that. Thanks. I'm just going to pause that share. Yeah, thanks, Hans, because I suddenly realized I've got to click in the, when I'm doing the sharing, I've got to include the sound in here. Share sound. There we go. Thanks for the pickup, Hans.
Hi, I'm Paula Nutting,
We have
Musculoskeletal.
video and sound.
Today we're going to look at shoulder pathologies, specifically our shoulder joint. You might have some clients that come in to see you that complain of a pain in arc. So they're fine down here. As they come up through there, they get painful and then they can clear it up and it feels fine when they get to the very top. Now, we've got multiple ways that we can treat this. One can be just simply softening and loosening off the soft tissue around the area, pec major, pec minor, bicep, rotator cuff, and sometimes we can even come in and punch up that little subscap. But it could quite often be the first rib. And in actual fact, that's what I'm going to show you today, is a little bit of a joint mobilisation on the first rib. We're going to use Kevin's left-hand side, not the right-hand side, and I'm going to show you what we do. So we're going to get his arm up on the non-treatment side, and you can see he's now got a diagonal angle for his clavicle and his scapulars. And then we're going to take the webbing of our thumb and finger, and we're going to feel for that first rib area. So we're going all the way down the lateral structures of that cervical spine on the left. And you should be able to palpate, especially if that first rib is elevated. So I can feel it, and it will be quite tender, yeah? Yeah, so I'm going to bring my web, cut right into here, and I'm just going to let him rest his head so it's passive movement. And I'm going to push down on that first rib. I'm going to mobilise it for probably about 12 to 15, just until you can start feeling movement. Now, once we've mobilised it, we're going to do a bit of a muscle energy technique. So what Kevin's going to do is he's going to try to laterally rotate to his right for me. So pulling around and up. It's about 30% to 40% maximum of the effort. They're going to hold it for 10 seconds. Take a breath in for me, Kevin, and relax the head as you breathe out. And then once he's relaxed, we're going to mobilise again. So we're going to do this mobilisation 3 times. I'm only going to do it twice because you guys are going to be able to do it 3 times. Again, you're going to turn your head up for me, rotating and pushing his ear into my hand, and then trying to turn so he's looking over that right shoulder. Take a breath in and relax on the out breath. Good work. So we would do 3 times, but we're also going to do another mobilisation and do a bit of a contraction on the same side. So this time, Kevin's going to push his head, lateral flexion, into the outside of my arm. So push down for me without rotation. So we're going to go straight down. How's that feel? Mm-hmm. Yeah. So he can feel that he's got some stiffness through that joint, and relax. It feels more tender than the application that you're putting on, but he's actually getting some good spring. Can you feel the difference there? Yeah. Okay, we're going to do one more time with this. So that's about 12 to 15 springs, and lateral turn to your left. So straight down. Fantastic. So you're going to apply 3 on each side. So 3 rotations and 3 lateral flexions. Big breath in. And relax on the out breath. Another trick to this is to make sure that other arm, the treatment arm, is down vertical with the hand internally rotated, because it will just allow a little bit more space in that glenohumeral region. Can you take that arm up through range for me? So up it comes. Now that was quite stiff earlier today. How's that feeling for you now?
Better, much better.
Yeah, okay. I'm Paula Nutting, your musculoskeletal.
So you can see by that, I'm just going to, so the way we were doing that action is by moving the opposite arm, the one that we're not treating up, it changes the position of the scapula and clavicle. So it gives you greater access in that region. And then by doing a rotation on one way, when we're rotating against, it means that we're forcing reciprocally to inhibit the muscles that we're targeting. So we're doing 2 things here. We're doing a reciprocal inhibition, and then by getting them to push, contract into, we're actually applying a muscle energy technique. So it's contracting, and then when it has a chance to relax, I used to take them into lateral flexion to do a stretch in there, but because we really can't pin down first rib in any of that movement, I found it didn't really give so much of a value. And in actual fact, what it was doing is it's quite highly nerve innervated in that area. So if I was getting them to do that lateral flexion, so contracting the scalenes in this area, and then making them go into a stretch, if it was affecting the brachial nerve plexus anywhere, then it would fire up and it would be counterintuitive. So where we normally MET and then stretch, find new bind, MET, when I'm working on the scalenes in this action, I actually don't do that. So there's a couple of you guys here, Hans or Haley. Have you guys got any questions or comments about that?
Paula, are you just with your, in that video, with your left hand, where you with the web of your hand, were you just holding it down? You weren't actually pressing in, you were just holding.
I was locking down and stabilizing, because
Yeah.
we can't actually access first rib, but we can definitely use that large web. If this is the rib and the rib space, what we can do is we can put a large web that will just press down and hold in. And the other thing I was doing is without bouncing, I'm actually bouncing to try to get bounce in the rib itself.
Okay. And when you had your hand there, were you actually on, I mean, I'm just trying to, so were you actually pressing down on the trap, pressing down more on the trap?
Pressing down more, right in as close as you can. If you palpate along the neck, you'll palpate down, and anteriorly to the trap, you'll feel that there's as much bony source as you can. That's as close as you're going to find first rib.
Okay.
There's probably more lateral if you've got a false rib or an eighth rib, a cervical vertebra. You could be feeling that space there.
Okay.
So my observation is that oftentimes there'll be an agonist-antagonist relationship. So there may be a splenus muscle on the back, either on the same side or often on the opposite side, that is being counterbalanced. They're trying to counterbalance each other in their action.
Yeah.
So when I'm palpating the transverse processes, I try to see if there is a tension on the front on one side and the back on the other.
Yeah.
Right. And sometimes it's not at the same level. Sometimes it'll be at a different level, but they will still be bracing. And then that involves more muscles deep in the laminal groove that are reinforcing between them. So it always is, a matter of the body trying to get the balance that it needs.
I totally agree, Hans. And with that, if we could look at the agonist and antagonist and just a role play, we could actually get them to do the action of the splenus on one side just gently, and then the action of the scaling on the other. So it's movement through common range until the brain and our motor sensory system kind of works it out. So it's really subtle stuff. Beautifully put. Okay, I'm going to screen share another of the two videos that I was looking at to try to help with different techniques. And this is the one I was talking about with palpating or moving the SCH.
Paula Nutting, your musculoskeletal specialist. Today I'm going to be discussing things about our neck and shoulders, and in particular the SC joint. So we have our AC joint that we normally talk about as therapists. And we also look at our SC joints that's not quite often treated. Now your sternocleido joint is part of the clavicle, and remember that it's also going to be affecting the scapula and how the shoulder sits in that socket space. You'll also notice that the sternum sitting here, that first rib butts right underneath the clavicle. And when we have fixations or stickiness in that SC joint, it can actually make differences to the first rib. And then we have a whole band of problems with the neck as well. So in this technique, we're going to be doing some myofascial work with our sternocleido joint. Kevin's a perfect example of this because he is a plumber, so as you know, they get into all sorts of tricky positions. Occasionally he will complain of neck and shoulder problems, and when I was palpating the AC and SC joints, he is actually quite stiff and sticking in that joint. So my thumb is just dropping down into the manubrium space and over onto the SC joint. thumb over thumb, and I'm going to compress down onto the SC joint and pushing it caudally. So your client is going to get that elbow bent, and he's just going to do an active movement. So he's taking the arm in and out. As he comes out, I'm depressing the SC joint. Now it's a little saddle joint and it can get a bit sticky. So what we're doing is, if you imagine that saddle, I'm pushing like a little lever. So we're drawing it down and back. It's a really nice joint mobilization technique. It can be quite tender to start with, but after a while it loosens off, and it's actually a lot nicer than the first rib stuff that I've done to Kevin before as well. So I think we're lucking up. Now I can actually start to feel that that joint is starting to get some movement or joint play. Can you feel that that's changed the last about 2 or 3? Yeah.
Just to note, can you see my biomechanics? I've got my arms really relaxed in space. The shoulders are depressed. My scapulas are staying down. My elbows are soft but not bent, and they don't bend and flex whilst I'm going it. It's all coming from the hip joint. So
Yeah.
I'm rocking.
So the arm movement is working as well. So just relax the arm. And when you think about the mechanism, as his shoulder is coming up and down, so the humerus is lifting up, we're actually adding a greater lever here as well. So we're encouraging the SC joint to do its saddle action. This is a great technique. Use it on anyone who's exhibiting first rib stiffness, shoulder pathologies, or even just when the SC and AC joints feel a little bit stiff and sticky.
Yeah. So if we're going to have a look at that, it's pretty self-explanatory. Use it for any time that you've got someone that's exhibiting anything that might be shoulder related. I wouldn't be doing it with people who have got osteoporosis, obviously, because we're working on bones. You can, but you'd have to start gently and or get just a tick from their doctor saying that that's all right to be working at the joint spaces. Also, if anyone's got arthritis, you could actually get arthritis specific of those joints, and that will inflame it up a little bit. Also, anyone who's got rheumatoid arthritis that's in the inflammatory stage, avoid doing any joint stuff on anyone in the acute phase of RA, because they need to be, that pannus is creating an issue in itself. So we need that's like gentle warm water and things like that. It's complete change of action, how we would treat those people. So any questions or comments on that, Hans or Hayley? Hands is up.
So I have on my right side at least 3 times I have had my shoulder jammed where it tore in the clavicle manubrium joint there. So that's an area that I have to watch. And in my particular case, a medial traction at the proximal end of the clavicle is most helpful for me. And then when I do movement, that supports the joint to stay where it doesn't pull on the ligaments that were previously torn.
Yeah.
So
you take in and draw towards the manubrium.
Right. That gives the support for where my ligaments have previously torn and tend to get fatigued and start to form, an arthritic complaint. So
how often would you
different ways we can help, by asking, does this feel better or does this feel better? You can find what pressure, traction, or distraction is going to give the most support.
So with the patient who comes in to see one of the therapists who has got medial ligament, ligament damage there, with range of movement, they would be complaining that they feel pain here. Is that correct, Hans? What would be the symptom picture?
Right. So, yeah, so I wind up, like I said, I've been moving wood today. So I feel the stress on those ligaments that should be holding that joint in place.
Yeah.
And so by supporting it and then doing the movement, that improves. And so sometimes it's the same with the rib head, then where it goes into the spine, that the pressure in the direction that's supportive at the rib head and then doing the movement can give relief.
So how long would you hold that? Was that like a 30 seconds and movement? Because I'm trying to get if we've got therapists out there that want to learn how to apply this, what's the take home homework for them?
Well, like you were demonstrating in the video, generally doing the movement 3 times and then find out, does it feel like it needs more or is that too much?
Yeah, yeah, cool. Thank you for that. And they could also apply a little bit of kinesio tape just to support that if it's in an acute phase, I suppose, just for as long as they're doing the active movement. So I suppose if you're at that point that you actually know that you've got to do a whole day of lumber chopping and apple picking, which is what you've been doing right now, if I'm getting it right, if we put some kinesio tape to support it before you went out, that would help.
Yes, that would be a good, way of supporting the person till the next session.
Yeah.
Or if they learn that they can do that particular traction or distraction that would help them, you always want to empower the client to be able to do self-care.
Yeah, agreed. Hayley, have you got a question on that video?
Well, it's just something just like a little bit lower down on the sternum, with the rib into the cartilage. I don't know if it's into the cartilage or into the sternum there. That area there being very, very tender on somebody. So
Along
could you
along the
sternum? Around about go down a little bit more there.
Okay.
So right, like on that rib joint there, I've got a client with severe pain there all the time, but it's actually, it feels like it's a few more ribs, but I don't know whether that's, I said to her, maybe it's costochondritis, and the doctor also said it could be, but
yeah.
It's been like that for years now.
When you think about ribs, always follow the rib back around to whatever joint it's attached to in the thorax.
Okay.
And then you can work out, because commonly there's joints of greatest restriction, and I think T5 is actually one of the ones that the chiropractors quite often will do work on, because it has a stiffness to it.
Okay.
So just always think if it's tender here, and we quite often do see people who've got a tenderness along one or two single points. Like I'm more tender on the actually pretty good today because I did Pilates this morning. But check the ribs. Also check the organs that support the neural output for the ribs around that area, because if that same area is feeding the gut, if there's someone who's very acid refluxy or they've got issues there, that would correlate that it's probably a nerve root that's being irritated as well.
Okay.
And also don't forget that if the sternalis, that whole area through there, well, it's not a don't forget because you probably aren't aware, is part of, when we look at our functional back line, the pull that we get in our functional back line creates some shearing and stress along the apophyseal areas through there, and it tends to be a dysfunctioning lat dorsi on the same side.
Lat dorsi, okay.
Yeah, so you can actually get them to do that. That action where they come, you can test the strength of the lat dorsi on that side and give them some muscle activation on that same side. So just a really gentle hand pressing down on their thigh, just to try to activate that lat dorsi on the same side for about 2 minutes, and then just retest and see if it makes any change.
Okay, thanks. We'll try that.
They're my guesses. Hans, your guesses?
So one of the things is that you have to realize that when the rib goes up and down as you're breathing, that it acts like the handle on a jack when you're jacking a car up.
Yep.
And so as you bring it up, you're setting the jack, and you bring try to breathe all the way out. You're prying the vertebrae apart, and you increase the disc height. And so when people are not having functional breathing in the ribs, they begin to lose the disc height at the level where the ribs are not moving. So finding a comfortable traction that you can use at the sternum or at the rib head, and then helping the person practice inhaling and exhaling completely. And oftentimes then the brain gets reprogrammed to let the ribs move freely, and it restores a lot of function.
Keep talking. I'm just going to find something. Sorry to leave you in the lurch, guys. So what Hans was saying is exactly right. My partner's got shoulder pathology, so he nicks my bolster. So anyway, that's a perfectly good example. You can use a bolster and get them, so if they're stiff on this side, you get them to put the bolster on the contralateral side and get them to start gently feeling that they can roll out and get some space in their anterior space and just lie onto it. So they're going to be lying on a flat surface. I'd start with a bed, because these are quite, if you're stiff and restricted, there is some spring in it. You can see I can squeeze it, but they can be quite uncomfortable on a stiff back. Let's get rid of that video background. It's driving me mad. Yeah, so squeezing that'll make a big difference. So under one side, they can start with an arm slightly elevated and then slowly get up into a lovely big extension. And that'll open up that space as well.
And then just doing the breathing
Yeah.
when they do that. Okay.
Yeah.
Okay, that's great.
Just
Thanks.
breathing in and breathing out. So again, as Hans is saying, in inhalation, we're actually trying to open the disc space, but we're also trying to encourage the whole rib line to open up versus just opening the back and concentrating the front. So we don't want to be doing that. We want to be doing that.
Yeah. Okay.
So
Thank you.
There's another muscle involved that is seldom considered, and that goes from the sternum to the rib on the inside, the sternocostal interni, and that's a muscle of complete exhalation. So if they try to hold their breath out, that engages that muscle. And if it's holding a rib down, then after they've practiced trying to not breathe in for a few seconds and then let themselves breathe in, that will often release the muscle that's holding the rib down.
Wow, never heard that. That's fantastic. Where's it attach? Which like whereabouts in the sternum?
It's all down the sternum at each level. There's an internal muscle, and it's actually the one that is represented often by the dotted line in the deep front line, you see. Okay, but sometimes Tom Myers actually shows those interni muscles, but most of the diagrams of his, it's only one that I remember that actually shows the muscle, but it was not showing the deep line. So because it's on the inside.
Is there 7 or 10 or how many? Like
Right. So there's an anatomy, a series of small anatomy books by Compton.
Oh, yeah.
that shows the motor points of the major muscles, but that book considered those interni, and so the doctor had that in his library, and I brought it to his attention that, hey, we have these interni, and it's explaining what's happening with some of our clients that were not able to get a deep breath because those muscles of deep exhalation were constantly fixed.
Yeah, wow, that's cool. Well, I love these because I learn something new every day as well. We've only got, I was going to just keep this at 45 because we're doing it as an education training. I can try to find, I can try to track down, if you give me the grace, to see if I can find this video on the upper, I can show you an upper trap MET, Hayley, if you're happy with that. But if you're looking for more SCM, I'm just going to have a quick squeeze back here. Myofascial releases. So if you can just bear with me for a moment, I can hopefully track them down. Be under stretches. I put these under groups that would make stretching the SCM. Oh no, it's stretching the SCM. Stretching the SCM will still show you the same angle that we're going to be doing.
I'm Paula Nutting.
Yep. Okay. You got it?
Your musculoskeletal specialist, and today's video is on the sternocleidomastoid muscle. We're following the journey on neck pain and tips that we can do to sort those out. Today, our SCMs, or sternocleidomastoid muscles, attach at the back of the neck right down to the front of the collarbone. When these become tight, they pull our chin forward, and that compresses the back of the neck, which gives us headaches, eye strain, and lots of our shoulder problems that we see every day. By making the SCM muscle longer, it will promote our heads from being that chin poke to back into a normal skeletal alignment. It's pretty easy to do, and all you do is you look at the muscle here, and you can see I've got quite a big, strong, deep one. So we're going to shorten the muscle. So I'm bringing the back of my head down to my shoulder blade, down to my collarbone. You grab hold of the muscle, and I'm gently pulling my head back and away. So if I start down, I'm going.
So this is more of an active glide, and try to get your fingers as close behind the body of the SCM as you can. Now, if we're going to try to turn this into a muscle energy technique, we'd have our patient in supine, and we'd take the head. I'd actually bring her head into flexion with that lateral rotation. So I'm shortening the muscle. So my nose is going to be going. So my nose right now is going back and right. To do the test, I'm going to take it down, and so my nose is still going to stay in that position, but I'm going to drop my ear towards my left hip. And then when I can feel the first point of bind as I take it back, like when it starts to contract, they then go to push into that contraction. So they're going to pull in towards, down towards the collar bone at 70, for 7 seconds, take a breath in and relax at about 30% effort. But this is the action that we're looking at.
And away. You'll feel your fingers sliding down the muscle each time you go back. That's normal. It's exactly the right feeling. Shorten, come up and pull to get a really good stretch. We need to do it on both sides. So once you've completed one, 3 times, shorten the other muscle, grab hold and pull back. You'll feel a nice long stretch all the way. Some of you right up to that point, others maybe just underneath your fingers. Holding down and pulling back and sliding right the way down till you're touching the bone of your collarbone. Do you suffer headaches?
Blah, blah, blah. Okay. I have a horrible feeling I start singing at the end of that video, so that's why I'm canning it right now. Haley, did that help a little bit? I know it wasn't an MET, but it was still kind of the actions.
Yeah, I mean, I do work on the SEMs, but the gliding is what I'll try now, with some clients. So that's good. And I was just thinking of MET because I've got a few clients that have got neck pain and they have the Dowager's hump, older clients in their 70s. Yeah.
That's the one we need to be doing.
Yeah.
Get them into where they're externally rotating their arms while they tuck their chin down, internally rotating their arms with their head up, and that will help do that movement that Hans is talking about, that stiffness at C7T1, and that'll help with that glide back through there.
Okay, thanks.
That's all right, no problems. All right, any other questions or comments or things that we want to cover over? Either of you? Or anybody out in Facebook land who will be watching this video when I chuck it up there later on today? Okay, so everyone be happy, be healthy, be well. Welcome to spring for the Southern Hemisphere. Yay.
Yay.
You've got autumn coming with all those beautiful or fall leaves as they have over up in the north. And for Haley and I, who are in the non-pandemic states of Australia, keep putting your mask on, do the right thing, and for those and send lots of love and care and support emotionally, if not physically, to our friends in the other states. And